So the next talk will be on OSA screening and diagnosis. What is the update, recent update in 2023? So please welcome.
Okay. So good morning, everybody, and thanks to Vishwesaran and the Yashoda team for giving me the invitation. So when it comes to screening and diagnosis of OSA, so there is a huge change in the last few years. This is because of the development of microprocessors, the software, artificial intelligence, and instruments that are being coming up, different companies that are being coming up with different instruments. And so, but the basic thing remains the same. That is, the information source that is critical for both the screening and the diagnosis is a good patient interview, a physical examination, the medical history, and ultimately the test, which includes the past and the present to form the diagnosis. So whatever the recent advances, whatever the artificial intelligence that is coming up, and the technology that is coming up, patient interview, the history, and the physical examination always remains the cornerstone. And what is known to us, the history, which includes the nocturnal symptoms and the daytime symptoms, should be taken into account, and good history is what is very important for screening of the patient. This will increase the pretest probability of having an obstructive sleep apnea. So it includes the nocturnal symptoms, the snoring, the witnessed apnea, the gasping, choking, insomnia, and restless leg, whereas the daytime, the non-restorative sleep, headache, excessive daytime sleepiness, the fatigue, and cognitive defect. In fact, if one of the tests become negative, the repeat test, and there are different studies which have shown that a repeat test becomes positive in that. So if that is the history is very important before going and conferring into a final verdict that he doesn't have obstructive sleep apnea or not. Then comes the physical examination, which should include the body mass index, the neck circumference, the proper way that it should be taken, and the presence of retrognathia or micrognathia, and ultimately the examination, which includes at the level of the nasal cavity, the oral cavity, the hypopharynx, the anatomical abnormalities, the epiglottis, and ultimately the laryngeal and the tracheal stenosis and everything. A good, important event, you should take into account the Malampatti scale, which includes the class 1 to the class 4, and ultimately, a Muller's maneuver may be taken not in all patients, but in few of them to detect the airway narrowing, because we know that performing by attempting to inhale against a pinch of nose and a closed mouth with a fiber optic scope, and the resulting negative inspiratory pressure will cause the walls of the upper airway to collapse in the narrowed airway, and a positive test is suggestive of OSAS. And AHI is correlated positively with the Muller's maneuver. So one way can be done in that. The dynamic nasopharyngeal scope in the domain of the ENT, the flexible scope to examine the upper way, finds the fixed obstruction such as the DNS, and demonstration of dynamic behavior of the airway in condition which promotes and prevents collapse. So I'll just talk about few of the guidelines, and it was really a hot discussion in the morning that we have seen. So they recommended that the clinical tools that we have, and most important, the questionnaires and the predicted algorithm, are not to be used for diagnosing OSA in adults in the absence of a polysomnography or at least an home sleep testing. So these are strong recommendation. So they recommend that polysomnography or a home sleep apnea testing with a technically adequate device be used for the diagnosis of OSA in uncomplicated adult presenting with signs and symptoms and indicate an increased risk of moderate or severe OSA. That is the pretest probability of an high OSA. And also, which I was telling, that if a single home sleep apnea test is negative or inconclusive or technically inadequate, polysomnography should be performed to diagnose OSA, which is thought to be the gold standard. Now coming to the topic which was discussed in the morning, that is, polysomnography rather than home sleep testing should be used in the diagnosis of OSA in patient, and that is what the guidelines, with a strong point in favor of that, with significant comorbidities, which include the cardiorespiratory disease, respiratory, that is potential muscle weakness due to neuromuscular condition, awake hypoventilation or suspicion of sleep-related hypoventilation, or in fact chronic opioid medication use, or history of stroke or severe insomnia. Here a polysomnography level 1 study should be done. If clinical appropriate, a split night diagnostic protocol rather than a full night diagnostic protocol for polysomnography may be used. And when initial polysomnography is negative and clinical suspicion of OSA is high, and that is the importance of the history and physical examination, a second polysomnography may be considered for the diagnosis of OSA. Coming to the Indian consensus-based guidelines, here also the excessive daytime sleepiness and the ESS as a pre-test screening questionnaire. So the ESS can be used as a tool to measure the quality of life, and it is used to evaluate the treatment response rather than to screen. This is very important. It's not a screening tool. The Berlin questionnaire is moderately accurate, though there are other questionnaires, but it can be used for screening a patient of OSA. The stop bank questionnaire is the most appropriate questionnaire for screening pre-operative cases. And here, the gold standard is always the level 1 study, type 1 study in hospital or in laboratory with a technician attended overnight polysomnography. The role of portable in the INOSA guidelines, again, the portable polysomnography or out of the center sleep test or the home sleep testing is in all patients suspected of having OSA, portable monitor with type 3 or type 4 device is adequate for diagnosis when used in conjugation with comprehensive sleep evaluation and in patients with high pretest probability of moderate to severe OSA. Coming to the MSLT and MWT. So MSLT is considered as an objective measurement of the reported daytime sleepiness. It is not routinely indicated in initial evaluation. It may be indicated when excessive daytime sleepiness persists despite optimum treatment. Coming to the MWT, it is mainly used to assess improved alertness following therapeutic interventions. So these are not to be used routinely in all of the cases for screening. So here is an exhaustive list and the sensitivity and the specificity. Coming to the Berlin questionnaire, it is developed for the assessment of sleep apnea risk and with a sensitivity of 77 and a specificity of 44. The stop bank questionnaire is again a screening tool for preoperative, and the Epworth sleepiness scale is widely used for assessing sleepiness and response to therapy. The polysomnography and the home-based test and the oximetry, the level 3, level 4, here has showing the sensitivity and specificity of 79 in the home sleep apnea testing, and the oximetry, the range is fluctuating from starting from 7 to anywhere between very high test. So again, the same thing which has been discussed, the sensitivity and the specificity of level 3 and level 4 testing, and if the post-test probability, the pre-test probability is high, the sensitivity and the specificity increases to a higher extent. So coming to the diagnostic criteria for adult. So this will be already stressed when we are doing the workshop, but in the presence of one of the symptoms, that is the patient complains of sleepiness or awakens with breath holding, or the bed partner shows features of habitual snoring or breathing interruption, and the patient has been diagnosed with hypertension, mood disorders, and the polysomnography, or out of the sleep test showing 5 or more obstructive event, then a diagnosis of OSA can be done. Or if the PSG or the out of the test set showing 15 or more predominantly obstructive respiratory event, then a confident diagnosis of obstructive sleep apnea can be done. And this has been discussed in details by my previous speaker. I'm not going to those, the respiratory, the sleep stage, the eye movement, arousal, cardiac monitor, and the leg movement. But again, the gold standard remains the type 1 lab-based or with a attended study, and this is a strong evidence for it. So the advantage has been discussed. It's the gold standard, technical support available, more consistent physical oversight, scoring and standardized by the American on all other criteria. But the disadvantage again is that not much of level 1 studies are available here in India. The cost, the time factor, and again, which has already been stressed, is the first night effect. The patient cannot sleep there the first time when he goes to the sleep lab. And these are some of the examples of the type 3 device, which include minimum of 4 channels and must monitor at least 2 channels of the respiratory movement and the airflow to define an event, and which includes the nasal, the apnea link 1, which just monitors the nasal flow, the respiratory effect, the oxygen saturation, pulse, and the snoring. But what is more recent addition in the armamentarium of the screening of the obstructive sleep apnea recently are some of the portable diagnostic device which has addressed the OSA and the burden effectively. So this may include the disposable device, which include the one sleep test, the AcuPebble, and the sleep image ring, the radar-based technology, which includes the Sleepies and MyNight devices, and some of the smartphone-based device, the SnoreFox and the SomnoFox. So just highlighting the disposable one, the multi-night disposable home sleep test based on the peripheral arterial tonometry. This is the one sleep test. The clinical study validate against the lab PSG, and it is a high correlation in labs in few of the studies that has been taken. It has been approved by the European and the US FDA. So just to give a few points on this, the respiratory event has been detected on the concurrent analysis of the blood oxygen saturation, the pulse rate, the peripheral arterial tone, the sleep-awake discrimination based on the actigraphy and the blood oxygen saturation, just a surrogate measurement of the breathing and sleep, and there are some automated analyzing software. So the respiratory event is determined by analyzing the co-occurrence of the one of the following event of oxygen dissociation, oxygen desaturation, which has been shown in one of the epochs here. The vasoconstriction manifested decrease in the peripheral artery and a pulse rate increase. So this is the way that it has been picked up. So the contraindication is because it is impacted by alteration in the sympathetic response, impaired perfusion in the peripheral finger, drugs causing those, and in patients with clinically relevant peripheral vascular disease, they are to be a contraindication, but the strength is that it is accurate in few of the studies that has been seen, multi-night, and there are studies which have shown that multi-night testing for screening of OSA has a greater advantage, and they pick up more of the patients and high patient comfort and engagement. And a few of the studies which highlight that the night owl, the REI has a high correlation with the two systems of them, the MSSI, AHI, the response, the correlation is strong. So there are a few of these couple of studies which have shown a high correlation. Coming to the AcuPebble, I'm not going in details because of the constraints of time, but it provides automated diagnostics, and it is a validated diagnosis against the cardiorespiratory polygraphy, easy to use, non-invasive, and no training is required. And the functioning is based on the principle of acoustic sensing of the number of physiological sounds, including those generated by the respiratory and the cardiovascular system. Coming to the sleep image ring, here it functions to measure the sleep quality, the duration, the sleep disorders, diagnose sleep apnea, and also effective in showing whether the treatment of the managing the sleep disorder treatment is effective when you are using the PAP therapy or not. The technology used here is the cardiopulmonary coupling based on the calculation and the spectral analysis of the cardiovascular and the respiratory data collected during the sleep. The radar technology, the MyNight, which is clinically validated to detect the snoring and the breathing pause, and the technology that is used here is similar to what the bat uses at night to detect some objects there. So the sound wave reflects of nearby object, and some of them reflect backs, and the app utilizes this principle. And it is way to send signals, those reflected back into the microphone, and it detects the pattern of the sleeping and the snoring and all important aspects that is there that is to be picked up during OSA. And if we see, there are a few studies which have shown it to be sensitivity of 88% and specific of 80% with AHI of more than 50 events per hour when it is seen, and thus it has an advantage of significantly lowering the barrier of entry of OSA screening. So since the type 1 lab are less here in India, it's a good screening tool. The radar-based this device, the Sleepies, is also using some of the same principle, the power of sleep insight with a device placed next to a bed. It operates in a non-contact fashion and measures movement originating from the heart contraction and breathing pattern with a medical grade accuracy using the artificial intelligence there. And the hardware coupled with advanced machine learning algorithm enables the Sleepies to achieve clinical grade assessment in analyzing both the pulse rate, the breathing pattern, the body movement. And even it takes care even if the patient is covered with a blanket. There are some few smartphone-based devices, the SnoreFox and the SomnoFox. Basically, it uses artificial intelligence. The acoustics of the snoring sound are analyzed, and the sleep specialist received a detailed report of the anatomical cause of the snoring by analyzing the sound that is coming from the snoring and interpreting it from which the source of this sound wave it is coming. The actigraphy, which has been discussed by my previous speaker, it's a small portable movement detecting, typically used as a piezoelectric accelerometer that then generate voltage and when motion is detected across the plane. So not going in details of how the changes are there, and the polysomnography study and screening was there in the pandemic, but still again we are sure that the pandemic part is over, and in that when the pandemic was there, there are a few of the guidelines that has come up how to pick up screening or how to do the polysomnography. Home studies were used as a preferred method of diagnosis, with the equipment being delivered by mail to the patient to avoid contact, and also disposable sensors. And those who are not available, the recommendation was to follow the manufacturer instruction regard to the cleaning process, and wait time of 72 hours before using the equipment was done, so that at least the infection would have the virus was just not there after waiting for 72 hours. That was the thought process. So last part of my talk is imaging. There are a lot of imaging that has been coming up nowadays. The use of artificial intelligence. So what is the utility of imaging? So there are recommendations. Basically, the imaging was to pick up the level of the obstruction, but the guidelines that tells us that the various method available, probably the fiber optic nasopharyngoscope with the Muller's maneuver is found to predict more response to the surgery of UPPP. Other investigations like the cephalometry, acoustic analysis, the somnofluoroscope are outdated. CT and MRI do predict level of obstruction consistently, and hence are not recommended for routine use. But the volumetric MRI has a few of the advantage. It can be helped in using standard pathophysiology of sleep and underlying treatment mechanism, which includes the weight loss, the CPAP, the oral appliances. It has the advantage, but a few of the disadvantage, which include the cost. The metallic implants patients cannot be taken into the center, noise leading to the sleep disturbance, or the claustrophobia that causes the patient not a good sleep when they are in the MRI unit. Submental ultrasound is also another modality, and dynamic changes in the transverse diameter of the retropalate and the retroglossal airspace are determined in 3 maneuvers, mainly expiration during tidal breathing and forced inspiration, and in the Muller's maneuver, and they're picked up and helps in analysis of whether there is any obstruction or not. So to summarize, whatever be the recent advances, whatever be the artificial intelligence development and the software, patient history interview and clinical examination remains the cornerstone. Again, the gold standard is always highlighted. There is level 1 in hospital, in laboratory, technician attended overnight polysomnography. Home sleep study are useful for diagnosing OSA with uncomplicated disease, not recommended in patients with comorbidities like cardiac or drugs or neurological complications. Portable devices are there for screening, which may be disposable device, radar-based or mobile-based. They aid in screening and diagnosis of sleep disordered breathing with a high sensitivity and specificity. Imaging is there, and recent advances in imaging has been coming out. They're used in the finding out the anatomical level of obstruction and may predict response to surgery, but are not recommended for routine use. So thank you.